All right, everybody. Well, it looks like the participants joining has slowed down a little bit, so I thought we would go ahead and get started. I'd like to welcome everybody to our 6th installment of our weekly BPCI Advanced Spring-Summer webinar series. Hopefully those of you that have been able to join the previous webinars find them informative and useful. I'm Peter Luigi. I'm with Fusion5's Provider Management Department, and I've been charged with assisting all of our member physician groups and hospital clients with managing their post-acute network to ensure the provision of the right care and the right setting by the right people. And I feel uniquely qualified to do this as I've spent the majority of my 25-plus year career in the post-acute setting, both in the nursing home business as well as the home care space. And I'm very passionate about the BPCI Advanced program as its primary goal, which is to improve patient care through better care coordination, is something that I've spent the better part of my career pursuing and promoting. So today I'm joined by my colleague Sean Matheson, and would like for him to take a minute to introduce himself as well before we launch into the presentation. Sean?
Well, thanks, Peter. I share that passion for what I call care management or care coordination. It's all about bringing resources to the people that need it the most. Most of the cases in a bundled payment program will go across pretty seamlessly, but it's always the minority of those patients that need the majority of our attention. In actuarial terms, 5% of the people cause 55% of the costs, and so we need to be able to help those people, and that's really my passion and background of 20 years, care management, care coordination. And we'll look forward to discussing some more of these strategies specific as we talk about alignment.
Super, thank you. Okay, so today what we're looking at is how are we as a group going to maximize the BPCI Advanced program together. So we're going to talk specifically about alignment strategies between physicians and hospitals, gain sharing opportunities, the waivers, as well as our post-acute care providers. And so we just want to remind everybody that as you have questions, feel free to email them to us at the email address that's listed there. It's info@fusion5.us, and we'll be able to answer those questions for you as we go forward. So right off the bat, how does BPCI Advanced create and align incentives? And we just want to be real clear that we're not talking just financial incentives, although there are plenty of those involved in this program, but we're also talking about care incentives, being able to improve the level of care that we're providing. So the program, BPCI Advanced, was built on care coordination and incentivizing our providers to align by financial means, improving care and length of care episodes. So in other words, one of our taglines that I love is that we're really working towards getting our patients better faster. So there's an opportunity to reduce costs by management of variation and waste-driven over expenditures. There's gain sharing incentives, which align our providers, both hospitals, physicians, and our post-acute care network in the redesign of care that achieves savings and improves quality. And all of these improvements that we make with our physician groups and hospitals really do carry over to all of their pay types and patients. So it's not just a Medicare program that can benefit from the care redesign and these alignment strategies, but all of our commercial payers and patients can benefit from this program as well. Our competencies learned in bundled payments will lay the foundation for success in the entire value-driven market, which we all believe is where the country is headed overall.
So with alignment, we all talk about the triple aim quite a lot, of increasing quality, decreasing cost while increasing patient engagement. And that is the goal. The interesting thing for me is that oftentimes it starts with the financial incentives, because if the groundwork, if the structure isn't there, if the payer isn't going to pay for it or provide some type of incentive, then likely it won't happen as well with the providers. In BPCI Advanced, in contrast, though, Medicare has created this program that really does enable the triple aim. It enables financial incentives that then allow us to focus more on quality and to get the patient more involved and engaged throughout the episode of care. And we'll illustrate that in the next slide of the enabling factors of alignment which Medicare has provided. I like to think of these in concentric circles, really. We should probably reformat this graphic where you have kind of a Venn diagram with the triple aim at the center, but all of these concentric circles around it, because there really is a interweaving tapestry, if you will, of elements to create alignment. Starting with the third, there's that financial I mentioned. There has to be an incentive to do this. The data is, secondly, there is enabling of this, but you can't just be a data enabler, data aggregator. There are plenty of those in the industry, but that alone is not going to drive the triple aim. It starts with the care design, as we mentioned. The whole thing has to be structured. Fourthly, there, with provider engagement, there is no question that when physicians lead a value-based program, it gets better results. If you look at the history of ACOs, for example, the taxonomy of ACOs, which are physician-led, had better performance financially and with quality and with patient engagement over ACOs that were insurance-led. So this, for me, is a breath of fresh air, that BPCI is a structural payment and engagement program, but it's physician-led. And that, I think, is why BPCI was one of the most successful programs that CMMI has launched. And of course, everything has to be patient-centered. It ultimately comes down to the patient and how engaged they are. Kind of that 5% of people that account for 55% of our focus. Everything has to be geared right down to the care plan for each respective patient.
Okay, so heading into the first alignment process is really with our physicians and hospitals. So traditionally, Medicare, as we all know, Medicare has made separate payments to all the providers and multiple individual services. And that really has just resulted in the significant fragmentation of care with very little coordination. So care redesign and coordination really drive this alignment success. It's again, what the entire program has been built on is care coordination. So coordination through communication increases the alignment of the goals, getting patients better, faster in the right setting. Prior to BPCI or value-based care, there were no incentives. The providers were not aligned to stay involved after their segment of care delivery was complete. Now they're completely incentivized financially to ensure that care coordination and therefore patient care is enhanced. So again, the care model applies across the whole care continuum. We've got an integrated care model across the full continuum of care, and all of that is going to minimize that fragmentation that we talked about on the last slide. It'll help reduce overutilization, waste, and or duplication of services. It's going to eliminate variation, so we're going to be able to provide very predictable, consistent results and outcomes. And ultimately, and most beneficial, is we're going to improve patient outcomes as well as patient satisfaction.
A lot of this integration comes via the program incentives that we'll talk about on the next slide. Again, it's that idea of having the foundation and the structural components in place to enable this type of coordination versus fragmentation. So we'll talk next about these program incentives. So there it really comes down to two financial types of incentives, and these flow directly to you as the episode initiator. You have the provider incentive, which is the net patient reconciliation amount. In other words, underspending the target price. Bear in mind that 50% of your physician's professional allowable fees in the lower extremity joint replacement or whatever bundle it is can flow to the physician. So say, for example, there was your allowable on Medicare for LEJR is $1,400. He or she could receive 50% of that, $700. The excess funds then flow to you as the episode initiator, less, of course, our marginal fees. So that then can benefit your practice. That's the NIPRA, if you will. The second is the internal cost sharing that you can create, and we will help you with the expertise in specialized CPA firms part of OrthoForum, and we can help create those gain share opportunities. I think one thing you should look at with Fusion5 or any convener that you're looking at in this process here for the next 6 or so weeks is who has the right type of incentive to reduce your costs. For example, for your device. We are agnostic in that sense. We are not a device manufacturer. Our main investor is Owens & Minor, which by nature is a supply company. So they have the ability to work with the hospitals, and with the OrthoForum, we have the ability to work with the CPA firms and really get the lowest cost. A lot of times, you may be thinking, I already get the lowest device cost. We beat up on the manufacturer a couple of years ago, or the hospital already gets the best cost. They're part of a large GPO. What's really interesting, though, is when you bring everybody together, in other words, the bundle payment convener, the expert CPA firm, yourselves, the hospital, we often, in fact, most often find that there is more cost savings that can be generated. And this all is enabled by these waivers. In a normal circumstance, if you were to go to the hospital and say, I'm going to negotiate with you with the device manufacturer, and I'm also going to increase the efficiency of my surgical packs, but I want to share in those gains with you. That would be illegal under current statutory law. However, because these waivers are in place, this all can be flowing. So there's this recognition by Medicare that if you're going to coordinate care and create alignment across the continuum, there has to be a structure in place to share in the gains with each other. So the NIPRA, if you want to share that with anybody downstream, the hospital sharings that you can create for alignment, all of this is enabled by the waivers.
So the overall environment has been created by CMS and the federal government to enable us all to really align ourselves together, both providers, conveners, patients, caregivers, et cetera, to make sure that we're all headed in the right direction, the same direction, being able to be a little more creative with our care planning and be able to allow our patients access to services because it should be in that right setting, the right care in the right setting by the right people. And those waivers and all of these incentives really allow us to do that significantly. So as a hospital, why would our hospitals be interested in participating in this program with us? Why would they be looking towards this alignment or better alignment? And just kind of tongue-in-cheek, happier surgeons make happier administrators. If our surgeons at the hospitals are happier, the administrators, CEOs, the folks running the hospitals are going to be much happier as well. And utilizing the orthopedic partnership specifically, hospital negotiations with implant vendors may reap deeper discounts. Care coordination leads to more efficient services, both from the hospital's perspective as well as the physician's perspective. And that really leads to much better outcomes and overall patient satisfaction. Hospitals are heavily rated with their either their Joint Commission accreditation or other accreditations that they get. A big weight is placed on patient satisfaction. So anything that the hospitals can do to improve their patient satisfaction is really going to go a long way to make that hospital's life better. The hospital's internal savings can be spread across all of their service line and payer types. As they're discovering these savings, not only does it obviously apply to their Medicare patients, their Medicare fee-for-service, but all their service lines and all of their payer sources will benefit from the cost savings and the lower costs and better coordination. And then all the work that the groups do with ortho cases relieves some of the pressure from an overextended hospital case management resource. Because we are helping talk to patients prior to even surgery and managing their expectations as far as what their post-acute care is going to involve, we're able to assist in alleviating some of the responsibilities of the case managers at the hospitals because we've already had those conversations. We already know where the patient's going to go. they don't necessarily have to worry about the discharge planning. We can help them coordinate all that. So it relieves some of the pressure on hospital resources.
Two quick comments on this slide. As Peter was mentioning that patient satisfaction piece, HCAHPS has become a good portion of a hospital's factor for reimbursement with Medicare and with other services. I used to work for the University of Utah Healthcare, and we increasingly saw the factor of onto our reimbursement of HCAHPS, such that most hospitals these days engage in Press Ganey or other national tools. So creating these pre-operative conversations, as Peter was mentioning, it just helps the hospital with their HCAHPS when the patient has a clear care plan. They know clearly what their next site of care is. You can integrate those next site of care decisions, what you have spoken with the patient about preoperatively, into your order set, and then things just become automated for the hospital. They simply begin to follow those specific orders that you have, rather than having it in the realm of case management. It becomes part of your discharge plan for the patient.
Okay, so another alignment strategy is through the gain sharing that Sean and I have referenced briefly.
So the interesting thing for me with the Centers for Medicaid and Medicare Innovation, it was created by the Affordable Care Act, and it has the requirement statutorily that any type of innovation model it comes up with, such as BPCI, has to be tied to quality. I like that because this isn't just a cost reduction method. Now, speaking of costs, that is very important. There was an article that just came out yesterday in all of the major listservs, Health Leaders Media, Becker's Hospital Review, etc., Kaiser Family Foundation, that Medicare announced they will be insolvent in 2026. The previous Congressional Budget Office figures had that at 2028. Think about where we were 8 years ago, and think about then the short timing here to what that will be for what Medicare announced yesterday. So the imperative is here for the cost reductions. But in the spirit of AAA, we have to do things for the patient engagement and for the quality. So statutorily it is written, every payment reform has to be tied to quality. With quality, you are not, there's no onus to you as a PGP for the first 2 years. All quality reports will come from claims until 220. Most likely there will be some quality reporting after that. But the governor here on this, the governor of the engine, if you will, is not only this regulatory mindset that it has to be tied to quality, but it's also the mindset that to create care coordination, we have to be able to do so among providers that in ways currently would not be allowed, such as gain sharing with the hospital, NIPRA sharing downstream, if that's an alignment strategy that's best for your practice. And we'll get more into some of these specific waivers and the creative care planning that can take place.
So the aligning of provider incentives with outcomes is really important. Like I said at the very beginning, it's all about this care coordination to improve outcomes and incentivizing people to do that by helping them to share in savings as they reduce the cost. So I was once told by our fearless leader, Jim Guerra, that CMS Medicare cares about two things and two things only. One, their beneficiaries, making sure that beneficiaries are well taken care of and able to access the benefits that they've worked all their lives for. And two, the Medicare Trust Fund, making sure that, as Sean said, that doesn't run out by 2028. So those two things are really all that CMS cares about. And the biggest one is ensuring that we're providing quality outcomes. So the method has been advocated as a way of really encouraging providers to work very closely together and improve quality and reduce costs at the same time. But you can't have one without the other. You certainly can't reduce the cost and not improve the quality. That'll be completely contrary to the entire program. And to incentivize providers to deliver care more efficiently through improved coordination, again, very passionate about that. I've been working towards that for my entire career, is making sure that we're coordinating care. I think we can all come up with a multitude of examples where families or loved ones have had a poor experience in the healthcare environment solely due to the lack of coordination of their care. So this way, all of our providers become jointly accountable based on how they manage their resources. Many outcome measures are already being measured and can easily be attributed across multiple quality-based programs.
So we've touched into this slide heavily in a webinar that we had last week on the financial incentives. So we'll just kind of touch and go here. As we think about the alignment that can take place, the funds start to flow both from your net patient reconciliation amount, the amount you underspend from the target calculation, and from internal cost savings that you can create with the hospital. Those flow into your savings pool, flow to you, less our costs, to you as the episode initiator, and then the rightmost here icon represents your physician, that he or she can receive up to 50% of the professional fees, the rest going to the practice. So this is a very attractive financial program. Most practices in Classic who are with a convener experienced $1,500 to $2,000 in savings per episode. We're very encouraged by the target calculation data that we've received. Friday night, we worked feverishly this weekend to bring you specific reports for your practice. And we are in the process of having those individual conversations with you of what can the funds flow look like through these alignment efforts for you.
So now we're back to the waivers again, and how the waivers that CMS has applied for are going to assist us in alignment. So this is the opportunity that we've got to get a little more specific in how these waivers are going to really help to incite a lot more alignment with everybody involved.
The different types of waivers that exist, and you see those listed here, Stark, CMP, anti-kickback, are enabled through the cooperation or through the rule, I should say, the interpretation is probably the better word, of the Office of Inspector General. And those were in place in Classic. Those are being renewed currently between the CMMI and the OIG. These types of waivers now allow what I call creative care planning. There are right down to beneficiary incentive waivers at the bottom there, things that you can do and things which have shown effective to be effective. And I believe, Peter, we have another slide subsequent to this where we talk more specifically about those types of waivers. Or was okay.
I think it may be later on, but just a side note, we've had experience in BPCI Classic, and there are several groups out there, one in particular that has had real significant success in the beneficiary incentive waivers, and things as simple as being able to pay for private duty care through a home care setting. And this organization, the Campbell Clinic in Memphis, Tennessee, have been very, very successful at coordinating that relationship with that provider, which would be unheard of if we didn't have that beneficiary incentive waiver. So there's just a multitude of opportunities here that these waivers provide real significant alignment and our ability to really be able to provide the right care in the right setting by the right people.
Just to throw out 4 quick examples, and Peter has touched on the one with Campbell Clinic, the ability to pay for private duty caregiver. That can creatively be set by your care managers as you're assessing the patient. What if there was this person at home, a non-medical person, to help get that person through, and in that way not have to go to the nursing facility. Pet boarding, as Peter mentioned. There have been successful examples we can connect you with and help you with in terms of assisted living facilities. Oftentimes they will set up respite halls, and I've seen this in practice in Bakersfield, California, where a person is enjoying the comfort of an assisted living facility versus a skilled nursing, and the respite rates are usually very small. that we can negotiate with the ALFs. And then they have the outpatient therapy that comes right there to them. And then a fourth one to mention would be transportation. We can help pay for and get the patient back to the PCP and back to you as the specialist. So a lot of creative things that we can do.
So now on to the alignment that we can provide with our post-acute care providers.
As I was looking at the slide and Peter and I were coordinating earlier, my mind was going back to a care coordination committee that I chaired for the Accountable Care Learning Collaborative. It's a DC think tank put on by Levitt Partners, former HHS Secretary Mike Levitt. And this was a group of 32 different organizations that came together around the country, and we did nothing for days but talk about care management and care coordination, right down to the differences between the definition of those two words. The idea here is that it's a concentric, multivariable, interrelated process. There has to be a post-acute management team, and that's part of what Peter and I and our post-acute team focus on. There has to be the clinical factors, and we have the clinical team there. There's the integration of data. We have to be visiting with our post-acute providers and with you on a monthly basis to say, here's the track record, and let's keep things within limits and pivot where we need to. This has to be multidisciplinary. In care management, in my opinion, it comes down to not just a nurse, but also the integration, if necessary, of PharmD, of RD, and even a social worker. And then of course, this has to all be based on evidence-based protocols specific to the disease state. So if you have somebody with comorbidities in a specific clinical area, CKD or COPD, we need to integrate those factors, those care protocols into the specific care plan for that patient. So it's multifactorial, and it really takes a number of things coming together to successfully manage the episode of a patient.
So the goals of care coordination across the entire care continuum, really, again, we've talked a little bit about this in prior slides, but it's variation of care reduction, so it's much more, again, predictable and consistent results. Patient-centered care is one of the goals. Joint decision-making, so we're making decisions amongst all parties involved, most importantly, the patient, physician, hospital, et cetera. Transition of care management, it's much easier as we're coordinating the care through the value-based care program to transition care from one setting to the next if it's really coordinated through a lot of significant communication. And that's where our case managers, the group case managers, all work together to make sure that those transition of cares go very smoothly. And into the post-acute setting, we'll have folks out there that will help manage that, or help the post-acute providers manage any transitions that they have to undertake, whether it's from a skilled nursing facility to home health, or from a skilled nursing facility right to home with outpatient, et cetera. So that transitioning of care management is really important and a huge goal of the alignment. Appropriate care settings, we keep talking about that, the right people in the right setting for the right care, and then appropriate levels of care, making sure that people are getting exactly what they need in that right setting. And overall, it's going to reduce overutilization, it's going to reduce waste and duplication of services.
One of the things that Jim, our CEO, talks about quite a lot is the goal of CMMI is really to create a bell curve, a standard predictability. If you think about, for example, let's give two quick examples, lower extremity joints and spinal fusions. On lower extremity joints, picture an X and a Y axis that goes from low to high, left to right with costs. The experience, for example, of CJR, and I believe a main reason why Medicare made it its first, at the time, mandatory payment, was that lower extremity joints were ranging from $16,000 to $32,000. from that low left to the high right, and even within close MSAs, metropolitan statistical areas, to each other. What accounts for that variation in LEJRs? The second example would be spinal fusions. Picture a curve which is like a camel's back, where you have really low costs, or then you can have really high costs. But what is the difference between the experience of the patient of those low versus high costs? Medicare really, as Jim said, wants to create bell curves. They want to create predictability in these episodes, and how that can take place is at a patient level, physician-led, where there are the right incentives, the right structures that enable us to do advanced care planning, I should call it proactive care planning for the patient. And all of these goals then can be achieved and the variation can be decreased. This is another illustration of what we've just were speaking of, that there are proven methods to coordinate care across continuums. Certainly, we see that in think tank work, such as the group that I mentioned prior that I was involved with. We see that in the experience of bundled payment conveners. And our next slide will illustrate some of those outcomes in quality and costs. But it's really this confluence of factors that Fusion5 can help you with. And that's the idea here that we want to create is, what is it that we can do for you to create these, to remove these barriers and to create this coordination. And these are a number or 5 different factors of what we create. And we can help bring all of these things together for you to create the outcomes that we'll show on the next slide. So you are likely familiar with the medical cost ratio, that for a health plan, every dollar it spends has a percentage reflected in their MCR of how much is being spent on claims for patient care and how much on administrative costs. Part of the Affordable Care Act was the goal to maximize the amount of spent on patient care and reduce the medical cost ratio, the administrative burden. Certainly, we are all familiar in provider groups with the administrative burdens. Well, part of the success factors of our founders in BPCI Classic were highly significant. The cost ratio for health plan was reduced from 83 to 68%. Just a very significant number. 30-day readmissions reduced greater than 15%, surgical site infections, SSIs greater than 40% reduction, joint infection reduction greater than, within 30 days, reduced greater than 25%, acute myocardial infarction within 7 days, reduced by greater than 20%, UTIs reduced by greater than 20%, patient satisfaction, part of that triple aim, was remaining at 98% or higher. The traditional thinking in U.S. healthcare is we just, if we spend more money, we'll get a better outcome. But 1/3 of our total costs, our total outlays, are estimated to be wasteful spending. We need to spend money smarter, and we can achieve that through care coordination. And you see that in the bottom line of BPCI. You've heard of ACOs that have saved 1.5%, and a minority of the ACOs accounted for more than 55% of the savings. Contrast that, and that's not to say ACOs won't be successful. I'm a true believer in that model. But contrast that to the quicker results that have taken place with BPCI. Just with our founders alone, in Classic, they were able to help practices reduce costs by more than $190 million. There was a study from another major group that showed a bundle payment convener that costs could actually well be into the $3 to $4 billion range within the next few years of the cost burden to Medicare reducing. So coordinating care it's the right thing to do for the patient, and it creates financial upsides as well.
And the primary reason why we're focusing on these successes is, A, as as Sean demonstrated, that a plowing of expenses more towards patient care obviously is going to highly benefit the patient. But also, if you look at and talk to any member of the C-suite at a hospital, primarily their chief medical officer, chief nursing officer, even the CEOs and CFOs, they will all tell you that the two worst things for them, because it really impacts, the two things that impact their patient care the most, it's readmission rates and infection rates. And so this program has been able to demonstrate a significant reduction in readmission rates, which is really beneficial to the patients, but also infection rates are significantly down. Those being the two greatest drivers of, a hospital's headaches. This program has been very successful in reducing. So all the more reason why we want to build that alignment between physicians and hospitals, because we as physicians and conveners can really help the hospitals improve the level of care that they're providing to their patients, at the same time reducing their costs and increasing their profitability. So it's a win-win all around, which is, again, all the more importance of having greater alignment between all the parties involved. So for next steps, and we've been on for about 40 minutes now, so we're going to give about 20 minutes of your lives back to you. But we're continuing with this series. Like I said at the beginning, this is number 6 of several more coming up over the next several weeks. Please be sure, if you've got questions from this webinar or any of the webinars that you participate in the future, just send those questions to info@fusion5.us. And we're also open to feedback as well, not just questions. If you find something particularly useful in the webinars, or something that's missing, or something that we're doing that's just rubbing you the wrong way, please tell us, because we want to make those adjustments in our presentation. So feel free to send questions and or just general comments and evaluations to that info@fusion5.us. As Sean had mentioned earlier, we were working feverishly over the weekend to produce our new opportunity analysis reports, which is proprietary to Fusion5. We've got this really amazing analytics platform that's been developed from the ground up, that we finally got preliminary target prices from CMS late Friday evening. We dumped those into this data analytics platform and spit out a bunch of opportunity analysis reports, which we had sent out to each of the groups. So if you haven't received those yet, please make sure you let us know, because we're under the understanding we've sent them all out. And we're feverishly setting up one-on-one webinars with you, or face-to-face presentations if you'd like, for us to step you through those opportunity analysis reports. They're very interactive. We've designed them so that you can play with them and toggle between which episodes you select and which ones you don't select, the volume of episodes. You can either increase or decrease, and then you can adjust your KPIs, whether it be SNF utilization, IRF utilization, all that stuff. You can make all the adjustments to this template just to see which scenario is going to work out best for you, and we will set up appointments for you to actually walk you through how to do that, so that you can realize, in looking at our opportunity analysis and utilizing the solutions that Fusion5 has to offer, the potential savings that you could realize in participating in this program. So again, going forward, we're going to be helping you decide whether or not you want to participate in the program, and if so, which episodes you want to select to participate. So that's all coming up here in the very near future. So appreciate everyone's participation. Before we sign off, Sean, any parting comments?
No, I just want to say thank you and express my love for care management.
All right, everybody. Thank you very much. Enjoy your Wednesday afternoon, and we'll chat with you next Wednesday with our next installment of our Spring Summer series. Thank you all very much.
Thank you.